યસ ભાઈ
યસ
નીતિનભાઈ કેવી રીતે ચેન્જ કરવાનું છે?
તમે જ્યારે ઝૂમમાં આવ્યા ને એમાં વ્યૂ પ્રોફાઇલ કરો છો રાઈટ ક્લિક કરીને.
ના સર આપણે રમેશભાઈ તમારા ફોટા પર ક્લિક કરો, ત્યાં
હા.
3 ટપકા આવશે રાઈટ અપર એન્ડમાં.
હા એક્ઝેક્ટલી. તેમાં રીનેમ છે, નીચે જો એકદમ નીચે રીનેમ. તમારા ફોટાની રાઈટ એન્ડ ઉપરમાં જો બ્લુમાં 3 ડોટ છે
એને ક્લિક કરો.
રેઝ હેન્ડ છે, મ્યુટ છે, હાઇડ
નહીં નહીં, નીચે નહીં, તમારા ફોટા પર.
ના રીનેમ. યસ યસ
તમારા ફોટા પર.
ફોટા ઉપર નીચે નહીં.
હા હા યસ ડોક્ટર રમેશ.
શ્યામ નહીં આવ્યો તો શ્યામ, ભાસ્કર, ચેતન.
થઈ ગયું નીતિનભાઈ? દેખાય?
હા આવી ગયું બરાબર.
ગુડ ઇવનિંગ સર.
મનીષ
કેમ છો સર?
બસ બસ મનીષ.
ગુડ ઇવનિંગ સર. નીતિન સર, અભય સર, ગુડ ઇવનિંગ.
યસ
ગુડ ઇવનિંગ મનીષભાઈ.
ગુડ ઇવનિંગ સર. Yeah, good evening. YouTube live started.
हेलो मनीष.
Yes.
मनीष भाई,
Yeah, good evening sir.
फुर्सत में है क्या? वो भी कम है क्या?
अभी तो काम हल्का सा खुला है, बाकी ऐसा कुछ है नहीं.
You go to evening 7 or continue till 9?
Sir, I'm in ICU practice, so we have like rotation work. We don't have like open. Yes.
Okay, okay. रामकृष्ण सर भी जान हुआ.
रामकृष्ण परमहंस.
Good evening, sir. Good evening.
ગુડ ઇવનિંગ ડોક્ટર રામકૃષ્ણ.
Good evening, sir.
भास्कर भाई मुंह दिखाई करो.
Hi.
यस, एक्स्ट्रा पैसा नहीं है. अरे अभी आईपी अभी किधर है तुम्हारा? आईपी निकालो पीछे से.
आईपी है.
योर फोटोग्राफ बैकग्राउंड इज शोइंग आईपीए बैकग्राउंड.
दोनों वो निकालने को टाइम नहीं.
हाँ, you can right click on your click on the video and then say the background, change it.
Can you guide me? Yeah.
On your video, on your laptop, there is a audio and video. Video, there is a bar. Just click on that.
On video.
On video, just click on the arrow. And it will say your adjust background.
The blur my background. It is.
You can say blur or you can adjust background effect. There you can select whatever you want. You can have some nice.
You can have no background भास्कर. तो
none.
None also.
Yes yes none.
अब तुम्हारे ऑफिस का है, घर का आ गया.
घर का आ गया.
ये क्या ऑफिस का?
Maestro PID is here. Dr. Bala Subramaniam.
Hi Nitin.
Hello.
Namaskar, Ramesh, Abhay.
Yes sir. Good evening sir.
Hello sir. Namaste sir.
નમસ્તે.
ચેતનભાઈ બેકગ્રાઉન્ડ ડાર્ક બહુ આવે છે. આગળ ફ્રન્ટમાં લાઈટ કરો.
કરું ચાલુ છે પણ હું જરા લાઈટમાં આવું થોડું.
હા, તમે લાઇમલાઇટમાં આવો, આગળ જવાનું છે આપણે હજી.
बाला सर, नमस्ते सर. बाला सर.
नमस्ते यशवंत
सर.
नो शाम को कोई फोन किया है क्या? रमेश भाई कुकरेजा ने फोन करो ना.
Shared a link with him because he asked for the link. So 10 minutes back I shared.
हाँ okay. 3 મિનિટ રહી એટલે હવે કહું છું. હા.
Nitin is looking like a teenager with that background.
Whatever little hair is remaining, I have dyed it black, jet black.
Superb.
Chetan bhai.
Yes.
IB Mumbai has sent a mail. We
अच्छा,
regret
let me
we
check.
cannot take the midterm Piracy.
We'll check it.
Guwahati को दे दो.
We are live.
I'm just saying.
We are live on YouTube also.
अच्छा इतना जल्दी काउंट पे देना था ना.
साथ में कर देते हैं.
चलो ठीक है.
बिकॉज उसका एक अपने प्रोफेशनल नहीं है तो थोड़ा इधर उधर जगलरी करना पड़ता है. वो मनीष को साथ में लेता हूँ. एवरी मंथ करते हैं लेकिन देन वी फॉरगेट एवरीथिंग.
Shyam, please join.
It is technicality, so many technicalities.
Right. We have another 2 minutes to go.
So me and Manish
We
are,
should start in time.
always doing that.
I called Shyam.
Okay, fine. What he said? He's joining.
He's joining. Yeah, he's joining.
Hi, Manish.
Sir, good evening, sir.
Biryani, chapati.
Ketan, who is the admin? You are the admin?
I am admin.
You have to keep on, what do you
I'll
call
do
it?
that.
Mute people who are sometime.
Usually this link is shared with the very limited people.
I know, but still sometime, by mistake.
We will. I'll look at it. And I'll
Inadvertent errors.
I know.
Bala is at home?
Yeah, I'm at home.
Okay.
I finished my work early, 7:30 a.m.
Oh, good. Very good.
Hello.
Bhaskar is a late bloomer.
Or early riser and late to sleep.
No, I think all the faculty should put the video on, always, because when you speak and you can't see, then it doesn't look nice.
Yeah.
Bhaskar, keep your video on. Unless you have a bandwidth issue, then that's a different thing.
Bhaskar is, I think, speaking to somebody. He must be in his study.
Super.
Rangnath, Dr. Rangnath, welcome. Shyam?
हाँ सर.
Shyam, थोड़ा video on रखो. Because when you speak, people can't see you, then the connect नहीं होता है. हाँ, बस. Bhaskar, okay. I think we are good to start.
Yes.
Bhai?
See,
क्या लगा रहा हूँ? समय लेता हूँ.
1 minute to go. Still.
Bas 1
Okay,
minute to go.
you tell whenever you want to start.
Rangnath sir, good evening.
Good evening, sir. Very good evening, everyone.
Yes, sir. Good evening.
Good evening, sir.
Ketan bhai, good evening.
Hey, good evening.
Good evening, everyone, sir.
Good evening, sir.
Welcome.
Good evening.
Yes, good evening. Nitin is looking exceptionally fresh.
As if he was black before.
No, so it's all a trick of
You
dyeing
tell
your hair.
to us, no problem.
Nitin bhai has prepared all the cases in such a way that it would be an academic treat for the viewers. Because
Anyways, we are
most of
ready to start.
Yeah.
Yes.
So, good evening, everyone, all the listeners. Welcome to Super 11 series, which is a continuous effort of Pediatric Infectious Disease Academy since last year also. So now, as we have changed the baton, we have, like Dr. Rangnath sir has given it to Dr. Bhaskar Shenoy as a chairperson of Pediatric Infectious Disease Academy. But the endeavor to enlighten all of you with the knowledge and the infectious disease knowledge sharing is going to continue. So first, I'll have a word from Dr. Outgoing Chairperson Dr. Rangnath Darur sir to address. He doesn't like the word outgoing. Dr. Darur sir.
I am not an outstanding person. I will be always within the room.
Yes, sir.
So I'll be here and I'll be watching.
Wi-Fi
And I'll be,
2009, sir.
now I'll be sharing my views also with you people. Being the chairperson, I speak means then it's good. It's a dominating character. But now the responsibility is over. I am also a general member, delegate like a member. So I have the right to speak and express my views. So that I am going to start this season itself. Right? All the best for continuing the what I have started with the opinion and discussions with Bala Subramaniam and others. So I am very happy that what I have started is being continued. All the best for you. Thank you.
Now I'll request our chairperson, Dr. Bhaskar Shenoy, to say a few words, as well as he may announce the NCPID 2025.
Respected seniors, respected past chairperson, Dr. Shyam Kukreja, Dr. SBS, Dr. Abhay, and stalwarts like Dr. Nitin, Dr. Ranganath, and all the Dr. Ramesh Bhajania, who has been instrumental in continuing this program, and my secretary, Dr. Chetan Yashwant. It's an honor for me to start this session, which is the brainchild of Dr. S. Balasubramaniam. And today we have a special this thing that the WhatsApp group of Dr. Bhajania, and this is going together. We are hand in hand. Thanks Nitin and Ramesh for agreeing us to giving us permission to conduct it together. And this is, as I told, it's a brainchild of Dr. Balasubramaniam and aptly implemented by Dr. Daruru and Dr. Chetan. And I thought this is one program which is going to educate and give academic knowledge to all our members. Why not continue? Which good things which is started, we should always continue. That is my motto. Not just because somebody started, but because it's good. So the good things will continue. And thanks once again for joining all the seniors and friends. And we will have it regularly in this forum. And also we are going to have some current affairs series as it was there in the previous tenure. NCPID, we know that the secretary is standing there, the organizing secretary, and we are going to make it a very unique program with a lot of innovations. And I request all of you to attend the program. And I think the NCPID secretary, organizing secretary, to say only 2 words.
Declare the dates. Declare the dates.
Rationing is at high level.
I think I forwarded to Chetan to you, isn't it? I mean,
it is 8th, 9th.
October, no.
9th.
October 9, 10, sorry, at 10th and 11th, 12. It is at Hotel Four Seasons in Bangalore. So we have changed the venue for the for this reason, NCPID, because after a long time it is coming to Bangalore. So that's the reason Dr. Bhaskar Shenoy wanted to have it in a very near place, near to the airport. So the faculties are coming from other part of India will still feel it is don't feel very tight, and they will be more enthusiastic to give a good talk to us. So I request all of you to register for that one. The register link has been sent to the in our group, and Chetan will once again share that one.
So you said 9th, 10th, 11th October.
Yes.
So Dr. Ramesh, you were saying there's an imbroglio by the Central IP as the election process on. Is there?
Yes. Now every year, 1st to 23rd October has been fixed for election. First nomination will be declared and 23rd result will be out.
No. So you can hold a conference. You can't hold conference during that time.
You can hold a conference.
Okay.
But the conflict of interest and code of conduct. So before selecting faculty, you have to be choosing.
In a way, it's a good because political faculty cannot participate.
Okay, let's
Sorry.
So So just to give the overview, because this particularly we know that our series is going on every Thursday, last Thursday of every month. And unfortunately, fortunately, we have a WhatsApp group which is going run in Gujarat by Dr. Bajana sir, and Nitin Sai is scientific convener for all the activities of that group. So he announced that the same date. Then I called him that we are having a same date, so it will be date clash. And then we looked at the topic, it was the infectious disease. Then we thought let us merge together and we'll have a scientific discussion on infectious disease. Thank you so much, and I will request Dr. Manish Mehta to introduce the panelists and start the proceedings.
Yes, so good evening, everyone. So once again, we have a very interesting and common topic in our ID, that is rational antimicrobials in office practice, which is always required. I think this topic needs to be revised every 2 to 3 months. Otherwise, people forget and start writing antibiotics here and there. So today we have panelists, our eminent panelists. First of all, Dr. Shyam Kukreja sir, who is a senior consultant pediatrician at Max Hospital, Delhi. Our own Dr. Bhaskar Shinoy sir, who is the ID chairman this year. The dynamic secretary, Dr. Chetan Trivedi, and our senior consultant, ID consultant, Dr. Abhay Shah sir. And we will try to welcome our moderators, none other than Dr. Nitin Shah sir, who is always charismatic and dynamic. Welcome, sir. And Dr. Ramesh Bajana sir, who is the vice president based on. Welcome, sir. So I request you to start the session, sir.
Just if Dr. Bala Subramaniam, whose brainchild is this particular Super 11, just bless a sentence, sir. Bala sir.
Let me not waste the time. All the best. We have a fantastic panel. I'm sure we will enjoy and learn. Thank you very much.
Well, thank you, Chetan, all the office bearers of the ID, Dr. Bhaskar, Dr. Rangnath Daruru, my friend Dr. Bajania. As Chetan already said that we had already declared our Gujarat WhatsApp group webinar, and lo and behold, it fell in the same date and the same topic. Very graciously, both the organization agreed to do it combined, and I'm really happy that we are not duplicating effort. So today I thought we'll discuss the rational antibiotics in office practice, because that's where the maximum abuse of antibiotics can happen. And that's where you now many times people use wrong antibiotic for the wrong reason and for the wrong duration, etc. Maybe one more seminar down the train we will also do on rational antibiotic in indoor practice, because that's a serious issue in many hospitals with a lot of resistant bugs coming through in major tertiary care hospitals. And it will be also interesting to that maybe study that pattern also. But today we'll focus for the common member, and we will do only for the antibiotic in the OPD practice. And we say that when you leak either from the above or below, you don't use antibiotic. I mean, that's the bottom of the message, that you have leak from the nose, that means a URI, or you leak from below, acute watery diarrhea, don't give antibiotic. That's where the maximum abuse happens. But there might be certain indications of using antibiotic even in those areas. And that's why today we will discuss basically rational antibiotic practice in respiratory infections, which is usually upper, or some pneumonia which can be treated on OPD basis. We'll take skin and soft tissue infection, because that's again the second common reason where antibiotics are used. Third is urinary infection or UTI, which are OPD based managed most of the time, unless it's severe pyelonephritis or a very small baby. And then last but not the least, we may take up some viral infection with high counts and so on and so forth. So I will hand over now to Dr. Bajane to start with the first discussion about the RTI.
Yes. Good evening, all dignitaries from the ID and our members from Gujarat Pediatricians WhatsApp group, and respected seniors and dear friends from IEP. So, as Nitin Bhai said, we have divided into four categories: RTI, SSPI, UTI, and fever without focus. So, being into general pediatrics, first I would take RTI. Straight away going to Shyam. A 3-year-old child has a cough, coryza, and high fever since last 3 days. But in between the fever, child is normal and playing. Child is taking liquids, though the solid is less. So, will you give antibiotic, Shyam, in this situation? And whatever the reason, just cite.
I think Dr. Nitin told us, a leaky nose or leaky lower part, that's diarrhea, please don't use antibiotics. Now, this child constellation of symptom fits into that. The child has got cough, the child has got coryza, child has got fever, and this is the this is very common in our practice. and this is classical viral syndrome. And interfebrile period is play. The child is active and playful, so it is very suggestive that this child is having a viral illness. I think no need to give antibiotics. That's very, very clear. And this is the most likely a viral pathology. And in this patient, I'll see the patient in detail, examine, and after that, I'll write notes that if anything worsens, please come back. I think there's a word of warning here. Many people tend to do throat culture in such cases. I think it's a very bad idea because he says VIPS सर इसलिए मैंने throat culture कर लिया तो उसमें throat culture करके you pick up bugs which are just colonized bugs and you treat this patient of viral with some funny antibiotic. I think this happens quite common in practice and I've seen the doctor themselves treating their children with some strong antibiotics that this was the bug which we got in the throat. So that should be discouraged. I think if this is a viral pathology, please no cultures and just give a symptomatic treatment and the child should improve.
So, Shyam, you will wait for how many days?
These children of viral fever, they tend to have 3 to 4 days of viral syndrome. Occasionally, adenovirus may have a little longer one. And in that situation, because this child even can fit into ILI in the beginning on the day one. So I'll give a warning signs to them. If the child becomes lethargic, child becomes dull, inactive, and not accepting orally, or he has little breathing difficulty, in that situation, please come back to me. So I'll go with this. And I'm not going to investigate this child, to be honest.
So that's correct. Not to worry, but simultaneously to convey red flags to the
Yes,
parents.
red flags must be given in every case. You never know out of 100 which one is going to dispersion.
Yeah. Now, Abhay bhai,
Yeah.
1-year-old male has cough and cold for 2 days and now develops significant fever and left ear pain. So, as clinically we can assume that there is something wrong in ear. How will you proceed? And will you give antibiotics?
Yeah, so clinically, this seems to be a case of acute otitis media. And number one, what is most important requires thorough clinical examination, and along with it, we should not forget about the otoscopy. So if the otoscopy shows that there is a bulging tip in the membrane is little immobile or less mobile, if there is a loss of cone of light of reflex, or if the normal anatomical features are lost, probably I am dealing a case of acute otitis media. Now, majority in 50-60% it may be viral, but at the same time, the bacteria is most common, and the common is the pneumococcus, H. influenza, and Moraxella. Now, whether to start the antibiotic now will depend on two important factors. One, what is the age of the child? Here, the child is less than 2 years. So, the chances of complication is very, very high, and therefore, here I will give the antibiotic. Second important there, whether the disease is unilateral or bilateral. Here, though the disease is unilateral, the disease is very severe. The third factor is the severity. When the fever is high grade, 102.2 degree, severe otalgia which persists for 48 hours, or if there is a visible otorrhea, irrespective of the age and irrespective of severity, I would give the antibiotic. And the choice of antibiotic will be amoxicillin, 40 mg per kg in 2 divided disease, and for the duration of 10 days. That is very important. And once you start the antibiotic within 48 or 72, you get the response, the fever will come down, the otorrhea will disappear. But even if the child is asymptomatic, please do not ever forget to re-examine the child otoscopically because there is going to be a middle ear effusion. Now, this middle ear effusion is very, very important. It may persist from 3 weeks to 3 months. I repeat, from 3 weeks to 3 months. So, persistence of the middle ear effusion is a natural part or natural history of the disease. And because the child is effusion, you should not just go on adding the antibiotic or prolonging the antibiotic. So, this is a classical case of acute otitis media, severe degree in a child who is less than 2 years. Amoxicillin is a drug of choice and has to be given for 10 days in a dose of 40 to 50 mg per kg.
Now, what if this child was 6 years old?
So again here, if the age is more than 2 years, I think I will be little conservative. If the disease is non-severe, probably I would not give the antibiotic. But the same child does not respond in 48 to 70 hours, or the symptoms worsen, then I would start the antibiotic. But again here, the choice remains the amoxicillin. So in a child who is more than 2 years, non-severe disease, in absence of otorrhea, wait and watch policy is required. Only symptomatic treatment is required. Treatment of fever and pain is required. Antibiotic and withhold for a 48 to 72 hours.
So any role of anti-cold or local ear drops?
Antibiotic topical, no role, because the disease is behind the middle ear, and your antibiotic drop are not going to go beyond the tympanic membrane. So no role. Some AAP suggests that some analgesic drops may be useful, but most of the time oral systemic paracetamol is good enough. So there is no role of any antihistaminic, no role of any topical installation of the ear drops.
So, just a
Dr.
cross
Abhay, just
question.
to intervene, would your choice of antibiotic differ if the child has recurrent otitis media?
Yeah,
So then you are talking about
definitely.
12.
So yeah, so if the child is exposed to antibiotic in the last 30 days, and if the second attack is there, probably my choice will be amoxicillin, not the amoxicillin.
So why so what would the clav do which you didn't want to use it for the first time? I mean, which organism you are now targeting?
So because now the pneumococcal vaccine for the pneumococcal is already there, number one, and for that amoxicillin is good. But now we have two other organisms, that is Moraxella and other is the non-tapered hip, and they produce beta-lactamase enzyme. And therefore, we need to have beta-lactamase inhibitor, and therefore amoxicillin is the drug of choice in that case.
And the other thing,
second,
what about
one important, if the child has conjunctivitis, along with otitis, means otitis media conjunctivitis syndrome, then the state where the organism H flow, and here we state way up for will go for the amoxicillin, not the amoxicillin.
Okay, the last additional question. Suppose you may have a pneumococcus which is not going to be very drug sensitive or intermediate sensitivity, which may not matter. I mean, it may be serious enough for a meningitis, but for non-meningeal isolates, what is the role of high dose amoxicillin?
Yeah, so here this is I think this is the very typical case where the intermediate resistance can be taken care by increasing dose. That is double dose.
So when would you use 40 mg and when would you use 80 mg?
Yeah. So if the child has the exposed to 40 mg per dose, which with no response, number one. If the child has a recurrent otitis, number two.
Correct.
If the child has some craniofacial anomaly, number three. And if the child is immunocompromised, or if the child has a bilateral disease with a chance of getting hearing deafness, or hearing evaluation is not satisfactory at any possible time, I will upfront go for the amoxicillin ES.
Okay, let's move to another scenario where we don't diagnose it that commonly. Let's take the case of a 7-year-old girl who has got high fever for 5 days, thick nasal discharge, which is greenish and foul smelling. She also complains of frontal headache. Now, does your clinical presentation differ from the previous two children that we saw? And then now, would you give antibiotic? If yes, which one? What are you thinking of?
Yeah, definitely a child who has a fever, who has a headache, who has a thick secretions, which is a greenish and foul smelling. Definitely, it is probably a case of sinusitis. So generally, sinusitis will present with these symptoms.
Correct.
So the one thing is, if it is unilateral, I would definitely rule out a foreign body. That is the first thing in the nose. But having said that, once that is ruled out, then I will look at the sinusitis. And the sinusitis is more of a clinical diagnosis than the other diagnosis. So a child who has a blocked nose. So generally, the criteria for diagnosing is a prolonged persistent viral syndrome, or a child who has a severe symptoms, where there is a nose block, discharge, or congestion. Then
what about the local tenderness over the sinus? Is it a good sign?
Onset fever. These are the three things which even the RTI GEM says that these are the things. Then there is a headache. A frontal headache will definitely point towards a sinusitis.
And local tenderness over maxillary sinus or
can be that. If it's a older child, of course, definitely we can appreciate. Yeah.
Now, how will you prove that it is sinusitis? Is it needed to prove by doing exercise, or you can just start antibiotic and thinking it is a clinical sinusitis?
As I told, the prolonged, persistent, or severe symptoms, or new onset symptoms. If these are there, along with the scenario which you have told, I will directly go for antibiotics.
Which antibiotic?
Amoxicillin. Amoxicillin.
Same dose as otitis media, 40 mg first time.
Same as
current. Okay. Yes. How long will you give? It will be same at 10 days or
no.
a little longer?
We have to give little longer, maybe
like
up to 14 days.
14
2
days.
weeks. And then, or after the symptoms have disappeared, at least 1 week after that. So total, it will be generally 2 weeks.
Whichever is longer.
Longer.
Yeah, and same thing, like suppose there's a recurrent sinusitis, would you use a coamoxiclav or still go with high dose amoxicillin or either of them?
So if there is a recurrent episode, then probably we have to go for high dose co-amoxiclav, that ES whatever is.
Yeah. And would you investigate him further, say for sinus polyp or some complicated sinusitis, and refer to ENT for some surgical procedure?
If it is a first episode and if it is uncomplicated, what I mean, there is no underlying other predisposing factors, I will not investigate. So the predisposing, usually they will have a recurrent viral, or there is a cleft lip, or there are foreign bodies, or there are the child who has GERD, or a child who has immunodeficiency, or a child who has a ciliary dyskinesia or something like that, or if a child has
so these are rare, right? The commonest would be a healthy child, sinusitis, responding, not responding, recurring. Choice would be accordingly amoxicillin or high dose if the second, third attack, and a co-amoxiclav, and give for a little longer time. And if the symptoms still persist, would you then take a ENT reference to see that there is no complication in the Yeah, Dr. Abhay, you want to say something?
Yes, I'm coming. If there is no response to a good antibiotic, maybe even amoxiclav ES, I think it is important that we go for the sinus endoscopy with the help of ENT surgeon. And sometimes there may be a pus bucket, and once you remove the pus bucket, probably you will get the response to the same antibiotic.
Many times they open up the sinus into the turbinate, and everything. It's like a draining of an acid. Okay. Chetan Bhai is silent for a long time. Chetan Bhai, now this child on follow-up. The mother says before all this happened also, she used to have mouth breathing sometime. And now also everything is okay, but the mouth breathing is continuing and she snores at night. Now these complaints are there for more than 2 or 3 months. Now how will you proceed?
So this is a 7 years old child, right?
A little louder, your voice is muffled, Chetan Bhai.
This is a 7-year-old girl, right?
Yes.
Yeah. So one thing is that basically any child, if its complaint of snoring is there, we have to take it because it is not normal. Unless you have rhinitis, rhinosinusitis, or some running nose and nasal blockage is there, and if it is coming temporary, it's fine. Otherwise, snoring is not a routine thing which occurs in the children. So whenever there is a complaint of snoring, when the child is opens, like sleeps with the open mouth, we have to just think about it. Something is obstructing the nasal passage. That's why child is not able to breathe the nasally, and that's why they're keeping the mouth open. So most common thing which occurs chronically, if you see adenoids, that has been missed a lot. Usually it has been missed so that patient complaints on complaining since long, and maybe they is having a typical adenoid faces where they have high arch palate, they have upturned nostrils, or they have vacant look, making attempt because of the adenoids. They're having a hearing problem also, and they are also scholastic backwardness. So these all
teacher will complain the child tends to sleep in the school because he hasn't had good sleep at night.
So now a lot of work has been done by obstructive sleep apnea. So that is also one of the things which should come to our mind when we think about adenoid. So here in this patient.
So 1 minute. My basic question: this is adenoid hypertrophy. You may or may not do by doing an X-ray lateral nasopharynx. I'm sure in many children you do it. It'll show some obstruction. The question is: this is not probably infective, or is it allergic? Because if it's infective, it should have led to fever, some symptom. Whereas
yes, so typically adenoiditis is never been seen frequently. What you get is adenoid hypertrophy, and usually it is been associated with allergic rhinitis element. So whenever you have this kind of patient, usually we have it is simultaneously which is happening. So you have to always keep in mind allergic rhinitis, allergic component, which increases the size of the adenoids, which obstruct the airway.
So generally, such patient no antibiotics, rather to treat the allergy or the cause of it by some antihistaminics for a long time. Role of Montelukast, a lot of people give Montelukast for 2 weeks, 3 weeks.
I think
role of nasal steroid. Of course, this is not infectious disease, but it's part of our day-to-day constellation of symptoms.
Correct. No. We have to take care of it because whenever we have this kind of patient, we put a diagnosis of adenoid hypertrophy. They will ask, sir, it is how severe it is. Usually the severity is not by taking X-ray. You can just take the X-ray, show them the passage is narrowed. We can clearly show X-ray lateral soft tissue. We can take it and then we can show. But it's symptomatology which decides the treatment. Now, this adenoid hypertrophy, we know that this allergic element is there. That's why people are tending to go towards the Montelukast. But it is not been, it is having a black box warning, should not be used. The first thing, so if you want to try something medically, then it is intranasal steroid. That can be tried. It may act on allergic rhinitis, otherwise it reduce the size of the adenoids also.
How long do you give it in your clinical practice? 1 month, 2 months, 3 months?
We can give a trial of around 3 months.
Okay.
So 1 to 3 months is a range, but I think we
Alright.
can give up to 3 months, and we can look at the
Okay.
response.
Okay, the last question. ENT people now, I mean, a lot of pediatric ENT people, they say that it is very safe to do adenoid surgery. Previously, they used to do TAR. Nowadays, they don't touch the tonsil. They just do adenoid resection. And adenoid, unlike tonsil, are not one gland. They are like conglomeration of few glands. So they just shave it off to create a passage. And some of them may recur, but most of them don't. The symptomology improves. Your take, when would you ask them to, especially a 7-year-old child?
So we know that adenoids usually they start regressing after 5 to 7 years of age in a natural course also. That's why we may tend to go for this intranasal steroid. But it is really doing harm. Suppose patient is holistic backward, not able to sleep, always keeping them. So I think we need to intervene and go for surgery. So then we have to send it to ENT people.
Okay, Ramesh bhai, you can take the next scenario.
Chetan bhai,
Yes, Shyam.
Yes.
Who's saying?
I
Shyam?
think, yes, I think the most important thing these days is to do a nasal endoscopy.
Yes.
And that gives you a fair idea as compared to X-ray. And I think most of us are now doing more of nasal endoscopy.
Yes, absolutely.
This is
That
one.
is
And
what the
second,
question is in the chat box by Dr. Sanjay. That what is the role of nasal?
the second is always do impedance audiometry, means tympanogram in these cases.
Yes.
And if it's a B type of a curve, you know there's a fluid behind the ear as well. I think that becomes very handy. So if the child has got, your question was, when will you go for surgery? I think it's better for the pediatrician to decide. If this is a sleep struggle, I think if the sleep is a struggle for the baby, the parents tell us कि सर इसको सोता हुआ देख नहीं सकते, डर लगता है
Correct.
देखने।
See,
So
in the
there's
past,
apnea,
Shyam, I remember,
one,
I mean, it
two
was so
endoscopy.
common to remove tonsil and adenoid for children with different cough and cold. But now
Yes.
we are a little more restrictive. But I think I like your point that we should decide when to refer for surgery. Because
Absolutely.
if you refer to
I
ENT,
decide.
they would probably want to operate.
So one is if the child struggles. Number two is if there's a nasal endoscopy telling me it's almost 90% the airway is blocked. And third, impedance audiometry is also showing me there's a B type of a curve. Then I'm very sure this child is going to suffer. And I don't want to make the child suffer, and I'll tell them to get operated.
So I think
So
if
the
I can sum up, because this is a very common issue about adenoid hypertrophy, when to do, what to do. I think simple thing, child's nose opens the mouth, has probably little difficulty in sleeping and daytime sleepiness, school complaints. Such children should be treated symptomatically, maybe with intranasal steroid for 3 months. If they are okay, fine, leave them. If not okay, then refer them to ENT for an endoscopy. If it shows good obstruction, maybe surgery is a good choice, especially if they also have a middle ear issue. Am I correct?
Yeah, and
So that's what I wanted to
one
add
point, sir.
that
One point.
Yes, Abhay bhai. Yes, yes.
Yeah. So in other words, any child with a poor scholarly performance, hearing evaluation or difficulty in the speech, they must be thoroughly investigated for the adenoids. That is very important. And no X-ray nowadays. Only nasal endoscopy is the order of the day. Yeah.
Last comment by Chetan before we switch the gear.
So recurrent otitis media is, many times adenoids is causing that obstruction over the uterus. So that is the reason. And usually why people they take X-ray is because they get convinced. At the same time, now we have this endoscopy. You can show it on the screen.
Many times the poor patient come to say, "Sir, दूध पिलाता है, कान से बाहर आता है."
Yeah.
Okay, Ramesh bhai, next scenario.
So Chetan, here the age group is 7 years. As you said, most of the time it cures by itself.
So now let's. Oh, Ramesh bhai.
What he wants to convey that the growth of the lymph tissue is over by that. That's why there is hyper.
Yeah, but it's not necessarily always.
Not necessarily. No, what he wants to convey that I am.
In fact, with puberty, there is lymphoid hypertrophy again. So it's a very. I would rather go by functional incapability rather than size and the shape of the gland, no matter what X-ray.
And Nitin, this adenoid size decreases only in those cases of cases who have associated allergic rhinitis.
Absolutely, agree.
So if you have to only treat those cases who have allergic rhinitis.
Okay, Shyam, you have a question from Ramesh now. Let's move forward. We have many questions. Ramesh bhai.
Now 8 years old male has high fever, sore throat, vomiting, and painful swallowing. Throat examination shows severe congestion. And there are bilateral submandibular lymph nodes which are 2 by 2 centimeter in size and tender. So, as we can assume, what is granular pharyngitis?
See, this is fitting into a sort of a pharyngitis, or you can name it as pharyngotonsillitis, or you can name it as pharyngotonsillitis. And I think the gland which are normally enlarged in such cases is jugulodigastric, which are also known as anterior cervical lymph nodes. And they are very, very suggestive that this child has got pharyngotonsillitis. I think throat examination usually clinches the diagnosis. And if you take a Centaur criterias, or you can take Mac-Isaacs criterias, if the child has got fever, child has got absent cough, child has got lymph node, and I think NHS takes only these four criterias plus nodular
Painful
exudates.
swallowing.
Yes, and painful swallowing. So if you take all these criterias, it is very suggestive that this child is having a strep throat. And I'll think I'll be doing because it justifies giving antibiotics in such cases. So I'll give antibiotics in this case.
So which?
I think it's better to give penicillin, and because penicillin is not readily available, I give amoxicillin for 10 days. And the dose is simple, 50 milligram per kg per day. And the ceiling limit is for any age group is 1,000 gram per day, 1,000 milligram per day.
So just one question, Sham, that many ENT surgeons, when they see, they give for 7 days. And this is always a problem. We always decide on 10 days. Can you elaborate?
Nitin, this is carved in stone. I think we have not done many studies on this. And somehow I think no one is going to bell the cat to give a shorter course because there's always a concern of rheumatic fever, and that's the reason you want to give it. And the second reason is why we want to give a long course is the streptococcus is very notorious to become intraepithelial. That's the reason sometimes it's very difficult to eradicate. And second, it forms biofilm.
Biofilm, yeah.
That's the reason you have to give 10 days of a course. So that is the problem. We must give it 10 days, and there's a lot of justification for giving 10 days.
In fact, over-treating such patient antibiotic is one of the reasons why rheumatic fever is almost disappeared from at least middle and good class patients. Yeah, Bajania sir, continue.
Yes, yes. Now, same child on follow-up, Shyam, seems to be better, but you see some membrane like on tonsils. So, what is it?
See, membrane on the tonsil can be of several reasons. The commonest will be, I'll say, strep throat only. And there's a yellowish white membrane on the throat. The throats are very red and congested. The base is very red and congested. The jugulodigastric lymph nodes, which are very tender. So this scenario fits into classically strep throat. But if the scenario is little different, it can be something else. It could be diphtheria, it could be EB virus also. So the description in those cases is very, very different. So if you want, I can discuss that
Yeah,
also.
please elaborate each of them. Diphtheria first, though it's a forgotten disease. Let's remember, diphtheria is on rise all over the country. And the common age group for which now diphtheria is happening, more than 60% are above 5 years of age. Probably because they're not taking the boosters. So diphtheria, yes, we must keep in mind.
So they present with the difficult swallowing, they have hoarseness, they have a throat pain. Interestingly, the diphtheria patients do not have fever more than 102. That's something interesting. And the striking part of diphtheria is from a distance you can make out it's a very sick looking child.
Yeah.
Absolutely sick looking. And they have a membrane, and they have a membrane which is a pseudo membrane. How it is proved? As soon as you swab it to go for culture and you want to see what is the bug there. In that situation, what happens is it starts bleeding. So you know that's most possibly diphtheria. And this membrane is interesting. It goes beyond the tonsils, can sit on the pharynx, it can be there in the nose, it can be there in the larynx, and it can even block the airway. So in our times, we have seen large number of diphtheria in our hospital, but luckily these days they are very uncommon, and we hardly see one patient in 2 years or maybe 2.5 years. So this is something, the disease which is gone, but it's not out. So we have to be very careful. And as Dr. Nitin was saying, there's an epidemiological shift towards the up right side, and children of higher age group are getting more of diphtheria now. So you have to be very, very careful. So this is regarding diphtheria. Now coming to EB. See, EB and streptococcus are little different. For example, in strep throat, the child will come with a sudden pain on one particular day. कि कल बिल्कुल ठीक था, इस सुबह से बड़ा गला दर्द है. EB is a gradual onset disease. This is something very interesting about it. And the second is in EB, you may not have too much of a pain throat, which is a classical feature of strep throat. If you look at the tonsils in strep throat are angry red, and over that the membrane is sitting or exudate is sitting. In case of EB virus, the base is not very angry looking, but the membrane is there. So you can differentiate by that, and then you have a lot of lymph nodes in the neck. In case of EB, the child has got a lot of malaise and lot of weakness, tiredness, which is not
Body
after
ache.
days of treatment with strep throat. Hardly you have any malaise and all that. Hepatosplenomegaly can be there. So these are the patients who present with lymphoid hyperplasia. And
And the CBC will be a little different.
CBC is different because you will have high counts with more of lymphos, and there'll be a lot of reactive lymph nodes.
Yes. What
Yes,
you call
Amar bhai.
atypical lymphocytes.
Yes.
We call them typical atypical
Atypical, yeah.
lymphocytes.
Yes.
Atypical because they are not looking like lymphocytes, and they're so
Right.
typical. You see that in EBV, you see that in phenytoin patients, you can see it in hepatitis A. There are 4 differential diagnoses.
And
They look
hematologists
like
name them
blasts.
brownie
Yeah.
cells.
Yeah, brown cells. So they are type 1, type 2, type 3. We won't go in detail, but just to say, the lymphocytes are large, eccentric nucleus, and the cytoplasm is indented by the RBCs around. It is so classical that no, I mean, even a normal pathologist can make a diagnosis. And if you see more than 10% such cells, generally it is confirmed that it is EBV.
Yes,
And
Amar bhai, you wanted to add
only
something?
one point in EBV, sir has done right now. There is usually periorbital edema, which is present nearly 40 to 50% of the cases.
Correct.
So in a child who has got a sore throat, exudate tonsil, and periorbital edema, I think the diagnosis goes in favor of EBV.
Abe, classically upper lid edema.
Yeah, upper lid edema. Yes,
Which is,
exactly.
And
Yeah.
classically.
how will you prove besides CBC? Will you do a EBV PCR serology
no,
or do nothing?
We usually viral capsid antigen IgM we do it. VCI IgM.
Serology.
VCI
Serology.
IgM. VCI
All
IgM.
right.
VCI IgM.
EBV VCA has to be done. It is confirmatory, and that is the only test to be done.
So
Most
you
of the
do-
time, many times what happens, it goes unnoticed. There is some sore throat. There is not typically any membrane. There is some lymph node which is missed and prolonged fever. That patient may be picked up as EBV.
So we do usually VCA, IgG, IgM, and EBNA, and then you, depending on what is positive, you differentiate is a past infection or is a current infection, and then you. But anyway, it doesn't matter. It's a clinical diagnosis. Such children should not be treated with antibiotics, and just on follow-up they start improving, but takes long time, maybe 2 weeks, 3 weeks for them to improve. Okay, let's change the gear now. We come to Abhay bhai.
Yes.
We have a 2-year-old male child. Has fever, mild cough, and poor feeding. Small child, usual history in a OPD setting. Around day 3, he develops mild breathlessness. Now, there is no wheezing at that. I mean, the respiratory rate is around 45, and there are mild chest retractions. There are crackles all over, and his saturations are maintained on room air. So, my question is, how will you do investigations? Will you do an X-ray right now? Will you do a etiological diagnosis in an OPD patient? And whether you will do what investigations?
Yeah, so here there is a short history of fever, poor feeding, and some tachypnea, rapid breathing is there.
Tachypnea,
And
right.
cough is minimal. So I think it
Minimal.
rules out the airway disease. But at the
Correct.
same time, it goes in favor of the parenchymal disease. So probably which may be related to a acute community acquired pneumonia. But only for a thing which is differs from the bacteria is that crackles are generalized. If the
Correct.
crackles are localized, probably I would definitely go for the bacterial pneumonia. But the
Okay.
generalized crackles, I think it is more in favor of
Could
viral
still be
pneumonia.
a viral
Yeah.
pneumonia. Absolutely. So would you now want to prove etiology?
So if the follow-up is regular follow-up is possible, parents are well educated or very reliable, probably I may not start the antibiotic upfront in this case, number one. And he may be in a close follow-up. As far as the investigation is concerned, probably I will not do any investigation. We'll wait for 24 to 48 hours. If the child worsens, I will start the antibiotic.
So,
And
no,
do
when will
only
you do at least a CBC, CRP, and an X-ray test?
Ah,
Child
so-
is a breathlessness and cough and fever.
if the child is toxic, not taking feed, if the signs of severe pneumonia, WHO criteria severe pneumonia, means not taking breath, tachypnea, poor
So
feeding.
practically, will you not do a CBC, CRP,
Yeah,
and X-ray
so
in your
these are non-severe pneumonia.
honest opinion? Honest opinion. I would do it. I
No.
mean,
In this case, usually I go for the CBC, CRP, and if required X-ray test. This is why my
Okay.
routine practice. But what the literature says, what WHO says, it's a non-severe pneumonia. You should not go for the investigation.
No, forget WHO. Let's say what we do, because people should do. I mean, we don't want
at least,
knowledge before 5 p.m. different than knowledge from
at least
after 5 p.m.
I would go for the CBC, CRP, and X-ray test in this
All
case.
right.
Yeah.
Okay,
So,
let's move. Yes.
But
no PCR. No PCR.
No PCR, of course. Correct. Yes.
For audience sake, reiterate the history.
Yeah. So we said that diless fever, mild cough, and poor feeding, which could be any viral infection. But on day 3, day 4, he start becoming breathless. There isn't any wheeze, and there are crackles. And he's maintaining saturation in the room air. Probably also is feeding adequate, which means it's not severe pneumonia needing hospitalization. Now, such patient, whether you do a CBC, CRP, X-ray, we all say that yes, though WHO says may not be required, because that's for the community in the worst of the worst situation where investigation may not be easily available. But where it's available, I mean, it's fair to do this investigation. So, Bhaskar, now Abhay said it looks like cap. Now he had done an X-ray, maybe there is a patch or there's a bronchopneumonia picture. Now, will you give antibiotics? Which and how long?
Yeah,
this is a 2-year-old child. 2-year-old child.
2-year-old child having tachypnea, having those respiratory signs which are described by you. Definitely, it is a community-acquired pneumonia. And as you know, the etiology can be bacterial, viral, atypical organisms. But having said that, it is very difficult to differentiate at this point of time whether it is a viral or bacterial, though there are some criteria, but exact differentiation may not be possible. And I want to take a chance in such cases, and I will definitely go for antibiotic.
So which antibiotic?
Ideally, amoxicillin only, 40 mg per kg.
Suppose the child has not received Hib vaccine or pneumococcal vaccine.
Then I will go for amoxiclav.
So why? What does the clav do which amoxi will not do for which organism?
Yeah, the Hib, the HIB, Haemophilus influenza is known to develop resistance by producing beta-lactamase, whereas the Streptococcus pneumoniae develops resistance by mechanism of penicillin binding protein, PPB.
Absolutely.
So this is the difference. So that is the.
So I think I will reiterate for the audience what Bhaskar is saying, that you have pneumococcus or Hib as a common organism for CAP in our country. If a child has taken vaccine against Hib, it is virtually 100% efficacious. You are not worried about beta-lactamase production because strep pneumonia is always protein binding, and that can be overcome only by high dose or changing the antibiotic and not by adding clavulanic acid. So in an unimmunized child, amoxiclav may be a better choice. In an immunized child against Hib, amoxicillin is good enough. Yeah, please continue, sir. How long will you give?
So
and how will you follow up?
If it is a if it is a OPD basis, 5 to 7 days. And I will closely follow up this child. So, and follow-up will be the clinic. I will educate the patient as previously told, the red flag signs. If the tachypnea is worsening, tachypnea in the sense the breathing rate is worsening, the child is not feeding, child is lethargic or inactive. So these are these things that they should come back. And now it is very difficult
to such child you will admit. If the compliance is good with oral antibiotic, if such red flag signs have come up.
If the compliance is good, the child is improving, I will wait for 1 or 2 days. If it is not improving, child is worsening, or I check the saturation and saturation is not maintaining, respiratory rate is increasing, then I will definitely admitting this child.
Okay, you gave this child.
Pardon?
Okay, you gave this child 7 to 10 days of amoxicillin, the correct dose. They took it, child is fine, fever is gone, everything is gone. There was a patch which was right lower zone, big patch. Mother wants to know, sir, what happened to that patch? Why don't you do repeat X-ray? Would you repeat X-ray? If yes, when? If no, why?
I will never do a repeat X-ray in such scenario because the radiological abnormality can persist for weeks, maybe 4 weeks or 5 weeks also sometimes. So if the child is clinically well, child has improved symptomatically and doing well, then no need for X-ray.
Okay, Ramesh bhai.
The repeat X-ray, sir, repeat X-ray we will do only if there is a worsening or if I suspect some complicated pneumonia. Complicated pneumonia, I mean at least 40 to 72 hours after the appropriate antibiotic, the fever is not coming down, child is not improving. That is the stage I may repeat the X-ray. Otherwise,
to rule out empyema as a or a necrotizing pneumonia.
Ultrasound is a very good modality.
Perfect.
But
Correct.
you are talking about X-ray, so I am telling X-ray.
Yeah,
Correct.
perfect. So
Correct. Chetan.
never,
Yeah.
even if you repeat X-ray after 10 days, 15 days, there may be 50%
Yeah.
resolution. Parents will get extremely worried, whereas actually it means nothing. Yes, Ramesh, but continue. The
Yes, sir.
last
Now,
scenario
Chetan,
is
same situation. What if this child was 8 years old?
Okay, so 8 years old patient is coming with fever, high grade, cough, cold, and we are suspecting pneumonia. So I think that atypical organism we are keeping in mind.
So,
So
do you add
atypical.
macrolide upfront?
So yeah, mycoplasma nowadays we are seeing a lot. So in
yes.
this age group, it fits into the mycoplasma pneumonia. So if we are having that typically maybe a walking pneumonia, there's coughing is there, child is not very toxic. But if you take an X-ray, many times what happens, the X-rays will surprise you because X-ray, the intensity of the X-ray is so bad as compared to child is looking normal, right? So
Correct.
in that case, it's a mycoplasma. We can definitely add on macrolide upfront. But if this patient require hospitalization or if patient is having some like fever high grade which is persistent or not taking oral, we are admitting. I think it is not a bad idea to go for diagnosing it. So what
Correct.
I do is now I practice nowadays because we are looking at so many like mycoplasma, throat swab, multiplex PCR. I go for it, and if it is a mycoplasma positive, X-ray is showing a patch, then I go for mycoplasma IgM also. So if we can have both positive PCR as well as mycoplasma, that confirms the diagnosis. At the
You can
same
also do
time,
Coombs test if there is a fall in hemoglobin.
yes, but sir,
Yes.
yeah, if it is fallen hemoglobin, it's fine. Otherwise, these two is reasonably making me confident that is the mycoplasma which is causing this particular pneumonia. So I go for the antibiotics. Now,
So
Yes.
as
Now,
I'm making one statement. Now the experts can say that multiplex PCR, such a patient, first of all, in OPD patient, please don't waste money unless the
no,
child is sick. Anyway, he would be admitted. In admitted patient, may be worth doing, especially if they're in ICU. Multiplex PCR showing a virus and etiology is more advantageous than a bacterial.
yes.
Am I correct
So
in this
is
statement? Like suppose you see
so
a
it is
pneumococcus.
no. Sorry, I'll explain. If it is the PCR taken from upper throat swab
It is always
samples,
upper, yes.
no. If we are
Nasal
doing
swab,
it MCR
nasopharyngeal swab.
nasopharyngeal swab, then viral is a reason viral infection to diagnose. We take this particular nasopharyngeal swab. But for
Correct.
bacterial, we don't consider because usually the
Correct.
disease is in lower down, so it may not be
Exactly.
the causative organism. That's why I'm telling. If you get mycoplasma, if it is fitting into situation, and if you
Correct.
go for a mycoplasma IgM, it is positive, then it confirms that it is the pathogenic organism.
Okay,
now,
my
Chetan,
second
yeah.
statement. But just one more statement before you all put remarks. So you can put remark for both. The child is now admitted, is becoming sick. Now my registrar calls me, sir, I am going to shift to PIC because he looks sick and may need intubation. My standing instruction is that if you ever intubate, please take a mini ball from the lower tract
Yes.
and that sent for PCR. Am I correct?
Yes.
Absolutely.
Okay, now please put your
Yeah.
remarks. Dr. Abhay,
Yeah,
yeah,
only
and then
one point.
Bhaskar.
Yeah.
Yes.
So even if the child is 6 years or 8 years, the pneumococcus remains the commonest cause of
First organ.
pneumonia.
Yes.
So beyond 6 years or 5 years is not equal to macrolide.
Correct.
So
We have seen even a 3-year
yeah,
child with mycoplasma.
yeah. So no response to beta lactam and child more
Yes.
than 6 weeks. And what Dr. Chetan said, walking pneumonia or viral like feature or extrapulmonary manifestation, that is the bottom line for use of the macrolide.
So third statement, in a child who is not responding, is not very sick, I would probably add on a macrolide.
Yeah, yes.
In a child who is very sick and maybe even a 24 hour, I may actually add macrolide upfront.
Okay.
Is it a correct
Yes,
policy?
yes, I totally agree,
Yeah.
sir.
Bhaskar, you wanted to say something about the
Nothing. The upper respiratory swab biofire may show on 10 to 15% even pneumococcus also as a co-founder.
Yeah, exactly. That's what I
Exactly.
said. Yeah, correct.
So
Okay,
doesn't
Ramesh
mean
bhai,
always
finish off
that
this
it is
question.
a
Yeah, now
Yeah,
Chetan, you said that you see nowadays a lot of mycoplasma, and you have been using azithro also. So, do you come across azithro resistance?
Now it is chota muh badi baat, but I have seen very few, maybe 6 or 7 confirmed mycoplasma, both throat swab as well as the mycoplasma IgM. And unfortunately, I didn't get much expected response with azithromycin. So in first 3 patients, I couldn't get a proper response. Then started using levoflox. So I have experience of using levoflox and I'm getting the response. But I can't generalize the statement, but this is very small, 6 or 7
yes.
patients I have tried that.
What about doxy and minocycline?
See, doxy is supposed to be a good option or alternative, but I have not used it. Yes, there are people like Dr. Jaideep is also discussed that they have used doxy and they have good response.
So I just to remark that if you look at the guidelines, actually say that if you have an immunocompromised host, either because of past chemo or past medical, like I treat many of those patients, if they come with mycoplasma, then probably levoflox upfront is the drug of choice, because you cannot, I mean, you don't wait for azithromycin to fail. And adult, if you said an adult side, I don't know, Sham can vouch, tertiary care like Hinduja, adults don't treat azithromycin. They just start minocycline or doxycycline as the first drug. Abhay, you want to say something?
Yes,
yeah, only thing that levoflox, I think it should be kept reserved for the tuberculosis, multi-drug. So I think if the
But
child
here
is
is
more than,
life-saving,
no,
sir.
if the child is more than 6 or 7, I think doxy should be a preference over the levoflox, number
that's
one.
fine.
Yeah.
Okay,
And
okay.
yeah.
But I
All
don't
right.
have experience. That's you're right. I
Yeah.
said doxy.
No, so I mean, last 3 patients in Hinduja that I have admitted, 2 of them are of course post chemo, but they're like miserable on azithromycin for 6 days, and we switched to levoflox, and second day, third day it is fine. Next, then onward we started only levoflox, and all of them go home in less 2-3 days. So I think I have shifted to using levoflox in mycoplasma, especially if they are immunocompromised like my patients. Dr. Bajania, you can take rapid fire for the skin and soft tissue.
Yes, now this is very common situation.
Yeah, because these are simple things to treat, but correct antibiotic is never given. So that's why rapid fire.
Yes. So, Bhaskar, about Furancal, right? Topical or systemic antibiotics, and which and how long?
Yeah.
Furancal. Bhaskar.
Hello.
Okay.
Question?
Yeah. What Furancal, topical or systemic antibiotics, and if which and how long?
If it is localized 1 or 2, then topical only. There is no role for systemic antibiotics. Topical, I use mupirocin, and some cases this one ozanoxin. That also I have used, but most often I have used mupirocin.
So this ozenoxacin is mainly for not actually for any infection, but mainly for impetigo.
Mainly for impetigo, yes.
Yeah,
Impetigo.
All right.
It is not for other skin, only for impetigo, and it is quicker response.
How long will you apply, Bhaskar? 1 week?
5 to 7 days. 5 to 7 days.
I think if I come in, I think it's a very important thing. It's a very tiny sort of furuncle. It's a very tiny abscess. Okay, size is usually less than 1 centimeter. I think warm compresses to make drainage out, and many times you can do which is known as a needle incision of the boil.
Correct.
And just put a needle, everything comes out. It's a source control, and the child becomes okay. You may or may apply mupirocin, but it doesn't make any difference because once you have drained the pus, then everything is okay. But the size is bigger, then it becomes abscess-like. Then you have to manage like abscess.
So that brings to Abhay Bhai. How will you manage this?
Developing abscess? Yes, now developing abscess, which antibiotic?
If the abscess is more than 5 centimeter, I think you have to go for the IND. Other white complex is required. And if there are systemic manifestations, childish, toxic, multiple abscesses which cannot be drained, like your area, ear, nose pain, I think they require systemic antibiotic. And drug of choice will be first cephalosporin, that is cephalexin.
So which organism are you targeting when you select
mainly
an
Streptococcus
antibiotic?
pyogenes and at time MSSA, not MRSA. MSSA, though
Correct.
MRSA is common, but MSSA is more common.
So I think at a community base, it's okay in a non-sick patient to try just with cephaloxivin. If that fails, then you will think of an MRSA, but prove it. Just people just give linezolid just because there is no response. I think that's a misuse of the drug.
And if the MRSA is very high, then probably clindamycin also good option. We often forget clindamycin, cotrimoxazole, and doxycycline for anti-MRSA. I think these are drugs that will be used more often than our vancomycin, linezolid.
Yeah, Abhay, many times the abscess is drained. Now everything is okay, but the wound is taking a long time to heal.
Yeah,
so
it happens, but you have to look whether this underlying cellulitis is there or not. If
no, there's nothing.
then
wound is clean.
Nothing to worry. Just local hygiene is most important.
So after 7 days, you can stop the antibiotic and just keep on dressing it till the time, because the mouth of the abscess may take time to heal. All right, go ahead. Now you can take.
Bhaskar, in cellulitis, which antibiotics? It's a fairly common situation.
If it is a small, localized, uncomplicated, then I will give either cephalexin or amoxiclav.
How long?
7 days. 7 days. Yeah. And if it is complicated, and if there is a something like a penetrating wound or some pointers to staphylococcus, then I may add either clox or clinda, depending on the situation.
So I think in such cases, worth doing a culture from the local swab,
Yeah.
start and common antibiotic cefalexin, wait for your MRSA, MSSA, and then you can accordingly switch to the correct antibiotic.
Yeah.
Now, similarly, Chetan, coming to impetigo, tropical or systemic antibiotic?
It
This is
depends.
fairly.
If it is a, we know it is bullous or non-bullous. It's like it is localized area. I think we can get away with topical antibiotics. You don't require systemic antibiotics.
And here you
And
can use ozinaxacin if you want to use.
so yes, there is an option, oxynoxacin or mupirocin, but it
Mupirocin.
is supposed to be better effective, but no enough evidences. So mupirocin, it also works well.
So which impetigo will give oral, oral antibiotic or systemic
Systemic
antibiotic?
antibiotic.
So if it is widespread, say more than
Yes.
2 non-contagious areas are indicated, that shows that is a hematogenous spread. Then it is, if it is a perioral, maybe it's in a dangerous area of face, or there is
Correct.
systemic symptoms is there, or
Yes.
if you feel it is involving a deeper layer, in
Correct.
that case, you would like to force systemic antibiotics. And again, the choice of antibiotics remains the same, looking at the organism, and it is cefalexin, which is working very nicely.
Okay, the last question on this SSTI is to Sham. Sham, very common burns. Children get burns. They are small burns, OPD base you treat. Just topical antiseptic or a systemic antibiotic too.
I think we should avoid systemic antibiotics because it's unnecessarily creating resistance. But there are few situations where you may have to give prophylactic.
Like,
For example, it's a very contaminated wound. In that situation, you have to do a good wound toilet and then give some antibiotics. And secondly, some people tend to give it if there are burns in the genital areas because they feel it's likely to get contaminated. And then immunocompromise, I think that's an uncommon condition in day-to-day practice. And if the child has
Systemic
I think
signs like fever.
more than 10% burns, they get admitted and they have to.
Correct.
So
And I think admitted burns, getting infected wound is a completely different ball game.
scenario.
Multiple organisms, they can be very bug resistant bugs. That's why we will touch that when we touch the antibiotics in the IPD patient. But OPD patient, generally no antibiotic. High fever, systemic signs, immunocompromised, general area, etc. As Shyam said, you may give antibiotic. Okay, so anything on the skin and soft tissue, any of the expert want to add before we move to UTI?
No. Please go ahead, sir.
Yeah, okay, fine.
Yeah.
Yes, yeah. So, okay, let's start with Abhay.
Yeah.
There's a 2-year female child. She has
Yeah.
high fever, poor feeding, and crying while passing urine for 4 days. She was treated with paracetamol. Someone said, oh, it may be viral. Urine routine was done ultimately on day 4, which shows 80 to 100 pulses per high power field. Nitrites are positive. Leukocyte estrase is not known in the report. And urine culture is collected and sent. Now, what is the next step?
It's a presumptive case of urinary tract infection with a systemic manifest like fever and not taking place. So it's a complicated UTI, number one. We should have gone for the nitrite as well as the leukocyte estrase.
So nitrates are positive.
So it's a UTI. Now you send the culture. Now we target the antibiotic which works mainly for the E. coli.
It's a 2-year
Usually I go for the third gen cephalosporin. If the child is taking orally well, non-toxic, I think cefixime is good enough. If the child is to be admitted, if the child is young, less than 3 months, or the child is very toxic, probably, or not taking well, vomiting, probably injection, third gen cephalosporin. That is
what dose of cefixime?
Yeah, cefixime 8 to 10 milligram per kg for
not enteric dose. People make mistake. People
8
give
to
high
10,
dose.
even 8 milligram is enough. 8 to 10 milligram per kg,
and
maybe
this is
for
this
7
is the first
days.
episode. So how long?
7 to 10, by and large 7 to 10 days. You have started parental, switch to oral as soon as possible and wait for the culture.
Okay, Bhaskar.
Yes.
Patient is afebrile on cefixime. Cultures have come back showing E. coli resistant to cefixime, but sensitive to nitrofurantoin injectables like amikacin and piptazo and mero, etc. Now what will you do? You will change the antibiotics?
See, if looking at the culture report, it looks like a ESBL. Because it's resistant to cefixime and cephalosporins, it can be ESBL. But the thing is, if the child is clinically fine, then I would like to continue the antibiotic rather than changing.
Why? I mean, why? I mean, it's resistant. How is it going to work?
No, but how we will respond clinically? That is because there will be.
So the urinary MICs
in vivo and in vitro difference can be there.
No, so the point is that urine cultures give the report based on the MICs of blood culture and not urinary MIC. And many of the drugs are concentrated in urine.
Exactly.
That's why urinary MIC can be very high, which can overcome the resistance. So cefixime will still work. Okay.
At the same time, there will be in vivo, in vitro discordance.
There
So
is.
Yes.
drugs which is not showing the sensitivity in vitro, it may be working in vivo.
Absolutely. So that brings me to you, Chetan. What is the child was still symptomatic
And
If
culture
the
is
child is
positive.
with the above culture report now? So
So now we
asymptomatic,
have
you
to-
say you continue. Is symptomatic. Can I use nitrofurantoin? Can I use injectable amikacin? Or can I have to admit and give the other antibiotic?
So here, when you see the report, it shows sensitivity to amikacin. We consider this ESBL, right? So it is a good choice because this patient is, if it is admitted, definitely will go for amikacin. It
No,
is
he's not
better drug.
admitted. These are OPD patients.
So still, because there won't be any other drug which will be sensitive. Yes, nitropenetrant is there, but this is bacteriostatic drug and it should not be used for a treatment.
Correct.
It is to be used only for prophylaxis,
More
if at all we
prophylaxis.
want to do.
Perfect.
So no, so there is no option. We have to go either you can go for injectable OPD base also. Then
Correct.
Micacin is single dose, single a day. So if you can admit, is fine, but it is not compulsory if child is not looking that severe. But looking at a report, patient is not responded, definitely would like to go for IV amikacin.
So can you give single dose intramuscular amikacin on OPD basis?
But it is preferable to go for IV. But
So you put in a catheter and call the patient
yes,
every day
yes,
and
yes.
give over half an hour diluted in 100 normal saline.
Correct.
Never
Yes.
push it
No, never.
because it is the trough level which are very important for the ototoxicity. Abhay, what's to say to me?
The only thing now the chances of community acquired ESBL UTI is very high.
Yes,
So
yes.
probably many times we often go for amoxicillin upfront rather than cefixime because
Okay.
so that is very more. So now this sensitivity pattern is changing.
Okay. Ramesh bhai, continue. 6-month child.
Now what is the child? What is the child was still symptomatic above?
No, that is over.
That is over. Yeah.
Next
If
one.
this child, Bhaskar, now if this child was 6 months and
No, it's for sham. It's for sham. SK is sham.
shown to have grade 4 reflux on follow-up, will
Yeah.
you give antibiotic prophylaxis?
There have been a lot of revised guidelines by different nephrology societies in the world. And I think their consensus is there's no need to give antibiotics in at least grade 1 and grade 2. So there's almost a consensus on that. They
Correct.
feel there's no benefit in giving this. But
Mhm.
now this child has got a grade 4 reflux. In this case, the chances of getting the kidney damage is higher. So in these cases, prophylaxis does make a sense, and most people use this. Now, what is the drug to be chosen? That's the next question you have asked, and for how long? That's right.
Yeah.
Yes.
Yeah.
Because the culture is showing resistance to cefixime, resistance to so many organisms.
I think the policy of choosing a prophylactic drug is it should have a narrow spectrum. So if
Exactly.
you can't give amoxiclav for
Exactly.
months, you
Very
can't
good.
give cefaxime for months. It has to be very narrow spectrum. I think I'll choose between cotrimoxazole or nitrofurantoin, and maybe third can be cephalexin, but not any fourth one.
Correct.
So these are drugs to be chosen. And as far as nitrofurantoin is concerned, I find palatability is a big issue, even if you mix it with a lot of fancy liquids. But cotrimoxazole is good, okay, good
Correct.
enough after the age of 6 months. And
So
we prevent
at what age you can start cotrimoxazole vis-a-vis giving cephalexin? Like very small babies,
less
like
than
below
three,
6 weeks.
less than 3, 4 months, I'm a little concerned. And maybe up to 6 months, maybe I'm concerned for G6PD. And
This is
that's the
pretty.
reason after
So
6 months,
what
quite
dose
safe.
of cephalexin and what does the cotrimoxazole? It's not the therapeutic dose. What is the prophylactic dose?
I think prophylactic dose is 15 milligram for cephalexin
Hmm.
and 1 to 2 milligram of trimethoprim in the
Absolutely.
cotrimoxazole, and nitrofurantoin is also, I think, 1 to 2 milligram.
2.5 milligram.
Yeah, and to be
Yes,
given
sir.
only at bedtime.
Yeah.
Yeah.
Only once a day. Only once
Yeah.
a day.
So I think the
And
whole
same
idea
time of the
of
day,
this,
every day.
yes, the whole idea of chemoproxy is that when the baby is not voiding during night as frequently as during day, is a time when you want to cover and you don't want to have a sterilizing antibiotic, but that will lead to resistance in the systemic antibiotic use. It has to be locally acting for the meatus sort of, whereby the colonization is prevented so that the UTI will not happen. That's the reason why even if there is resistance to these drugs on cultures, you don't use the fancy drug, you use still simple cephalexin or
And plus,
cotrimoxazole.
I think it's very important in these babies not to allow them to have constipation.
Yeah.
The
Absolutely.
genital area should be
Clean.
clean from front to back. All these
Absolutely.
things must be given. I think is not only antibiotics, other instructions must be given so that the child doesn't get repeated UTI.
Hmm.
Ramesh
Now,
bhai,
Abhay bhai,
continue.
Yeah.
this child has high fever with shivering, vomiting, poor feeding, and toxic looking. So what will you think of here?
So I think this is a clear case of urosepsis and the potential organism ESBL. So naturally, all this does not going to work. I will definitely admit the child. And if we go for the broad spectrum, maybe a present tazobactam or even meropenem. I think meropenem has an edge because it's a toxic child, so it will take care of the AMPC producing ESBL as well. So the first choice either meropenem, secondly, say piperazine tazobactam.
So I think for our discussion today, we are discussing OPD practice. This is not your cup of tea to treat with cefixime. Admit them. This is one indication for true admission. We admit a lot of patients with so-called with very soft indication. This child don't mess around. Just send them to the hospital. So last question on the UTI, Bhaskar. UTI child is clear, child is fine. Now mother wants to know what happened to the organism. Doctor, do I need to do a repeat culture?
No,
No.
repeat
Do I
culture is
need to
not.
repeat? Do I need to repeat urine? What happened to the 100 cells?
No, if the child has clinically improved and you are given proper appropriate antibiotic, no need for repeating the culture.
Correct. So now the pediatrician did not follow your order, Dr. Bhaskar, and he actually 1 month later he ordered for another urine culture, which is still showing E. coli sensitive to most of the drugs, but his child is afebrile. Now how will you treat?
It could be a case of it's a female child, if I'm not
Female
wrong.
child, yes.
It could be a asymptomatic bacteriuria.
Correct.
That's what I feel. So
Yes.
this need not be treated. If the child is not symptomatic, then I won't treat it.
So need not be treated or should not be treated?
Should not be treated.
Should not be treated. Okay. So sterile pyuria, in fact, without any UTI, so you should worry about immunological cause or rheumatological cause, RA or SLE or thing like that.
Or Kawasaki.
But child who has had UTI and now has sterile pyuria, just leave them alone and do nothing. Actually, anything on UTI the experts want to add on before we move to the last part of today's discussion, which is
Now, one small point is
Don't change the antibiotic in an improving child.
perfect. So that's one.
Don't
Second,
change the
don't do
antibiotic in an
routine.
improving child.
Don't do urine routine and culture repeated if the child is otherwise fine. Leave them alone.
Exactly.
Bhaskar, anything else?
The prophylaxis is the simple way to remember 1/3 of the therapeutic dose.
Exactly. Perfect. I think that makes sense. Let's move on to the last part, and that is a 5-year-old child develops fever, which is increasing in frequency and the height of the fever over the next few days. There are no localizing signs or no systemic signs to suggest a focus. He has been treated with symptomatic treatment, listening to Dr. Bhaskar again and again. They do not start antibiotic, do not start antibiotic. His CBC shows hemoglobin of 10 gram, which is little lower. WBC, which is 4,500. 40% polymorph, 60% lymphocyte. There are no eosinophil or basophil. And the CRP is 80. Now, blood culture is sent. Chetan, what will you do after the blood culture is sent? Will you wait or will you start antibiotic? If yes, what?
So this patient is having fever since how many days?
Say 5-6 days.
5-6 days. So I think it is high time that parents are also concerned what is the reason of fever, and we also are concerned.
Exactly.
We didn't find any localizing signs. So it's a non-localizing fever. And most common in our scenario is an enteric fever. We know that. And that's why what we have done is we have investigated, we have sent a blood culture rightly.
Well, on
And
the CBC,
CRP
is there indicator that it could be typhoid? Is there an indicator?
Yes. In this case, WBC on a lower side, not that less than 4,000, but 4,500. At the same time, CRP is high. So this usually indirectly gives me the evidence.
An absence of eosinophil. You give credence to that?
Eosinopenia is maybe you may find it, right? Here, if it is for 60 and 40, then it is eosinopenia, zero eosinophil. Okay.
Correct.
So then it gives me an indication, clear cut, that it's enteric fever.
So
even
which
if
antibiotic?
it is not giving me this thing indication, this is the time at least I will do something. So I'll definitely decide to start a treatment that is on enteric line of treatment, and we'll start with antibiotics.
So
if
which
the child
drug?
is, pardon?
Which drug?
So if child is looking like it's stable child, only fever, is taking, accepting the food and fluid reasonably, we'll go for the third generation cephalosporin, which is oral cefixime. We'll start with an enteric dose. That is 10 milligram per kilogram per dose. That is 20 milligram per kilogram day. We will start it. Then we'll wait for the culture as well as the improvement in the form of fever as well as other things.
Suppose the culture comes negative, how long will you continue and then stop?
See, even if it is coming negative, we have put a clinical diagnosis of enteric fever. I'll continue for 10 to 14 days. At 14 days or 7 days from defervations, whatever is life.
Whichever is longer. All right. Longer. So, Shyam, culture shows that is S. typhi, as rightly diagnosed, sensitive to ceftriaxone, azithromycin, amikacin. Rangnath, can you, Dr. Daruru, can you mute yourself, please?
Yes,
Chetan bhai,
yes.
karo na.
Who is there? But I'm not
No,
able to.
okay. Sorry, so I'll restart. Dr. Sham. Culture shows S. typhi, sensitive to ceftriaxone, azithro, amikacin, cotrimoxazole, and chloromycin, but resistant to ampicillin. He's on the correct dose of cefixime. Today, day 7, and the fever is still continuing. Parents are worried. Will you change the antibiotic, add azithromycin, or switch over to azithromycin, or do nothing?
I think first of all, I think check the MICs of ceftriaxone, what it is, because it's quite a good proxy for cefixime. And in that situation, if the MIC is less than 1 microgram per ml, so I'm very sure this drug has to work. But in many labs, the susceptibility range is given up to 4. And that's a problem. People may believe up to 2 or 3, 2 or 4 is okay, and they may treat. So this is one fallacy which should be taken care. And second, I think I'll go by the general condition. If the child is improving, the look is okay, sense of well-being has come, appetite is okay, and the fever has spaced out, there's no
No,
shivering.
fever hasn't. Fever, that's, if the fever had gone, there was no question.
Even
The fever hasn't.
even I think I've not seen a case in last maybe 10 years which has behaved like this. All of them improve on if the MIC is okay. They become all okay. And I think have some patience. If
No,
the
this
child
child
has
is
not
on cefixime, not admitted. He's on cefixime orally in the enteric dose, and day 7 fever is continuing.
and he's not becoming sick.
No, he's not sick except fever. Fever continues. The parents are worried about fever.
And if the MIC is okay, I think I'll still wait. There's no problem.
Wait,
Absolutely.
I think that makes sense. It may take up to 8 or 10 days for the defervescence to happen.
Absolutely.
All right, Dr. Abhay
These
bhai.
children generally, I think what we see in our practice is the child is otherwise okay, better. His fever is okay. He started eating a bit, and the shivering has gone, and still the fever is coming, and the parents are more concerned about fever. And even if you ask repeatedly, they say, "Nahi, वैसा ही है, वैसा ही है." But you go into detail and examine the child, you find the child is definitely better. I think it's quite okay and doesn't make sense to add another antibiotic. I have not done in last 10 years in any case.
Perfect. Abhay bhai,
Yeah.
what about use of cotrimoxazole? Old, nice,
And
good
also,
oral drug.
just sorry to say,
yes.
just rule out that some children, because we have a lot of visitors. कोई cold cough तो नहीं develop हो गया पीछे bad नहीं हो गया वो check
Oh God. So Abhay bhai, my question. Cotrimoxazole was an excellent drug for entry. We used to use it like plenty. Now we are seeing culture sensitive to would you switch to cotrimoxazole?
No. I will not say.
Okay. Would you use cotrimoxazole as an upfront first line drug because your experience of the last few culture is showing that it's sensitive in most of the patients?
No, because we are dealing with a MDR typhoid, and therefore.
Now, how do you know is MDR? I'm just saying. I'm not saying in this child whose culture has come.
And
even in fact, this culture is actually showing is sensitive to cotrimoxazole.
No, but still I will go for the third cephalosporin.
All right. And chloromycin, given a drug?
Never ever. I will not take a chance.
Please don't use it because you will your anti-fever patient will come to me with aplastic anywhere.
Nitin.
Yes, Bhaskar.
The first line, that is amoxicillin or ampicillin, cotrimoxazole, chloromycin, though they were resistant, then after many years now they are. But having said that, we cannot use because there is every chance that when you start using, the resistance will increase. So there is again we will go to that
same pattern. Yeah.
So it is not recommended to use those drugs again.
Okay, so okay, I will make one statement. You are using ceftriaxone and cefixime, and you already have a ceftriaxone resistant S. typhi, huge outbreak in Sindh province in Pakistan. Our Hinduja culture report shows there is on the threshold of losing sensitivity. So I say the same thing. You use so much of ceftriaxone. Why not switch to cotrimoxazole? Cheaper drug, easily available.
I think we can go for the azithromycin.
Okay, fine.
Why will go for the cotrimoxazole?
All right. So now parents are not ready for hospitalization for IV ceftriaxone. Can you give amikacin injector? Yes, sir. एक intramuscular single dose में आके लेके जाऊंगा.
No.
Salmonella
will not work on the intracellular organism. Salmonella is intracellular.
So don't get fooled by in vitro sensitive to amikacin by S. typhi. It will not work at all. It's as good as giving water.
And
All
same
right.
things are happen with Shigella dysentery also. When we
Correct.
saw so many cases of amikacin with dysentery, again it's intracellular.
And
Now,
in
Ramesh bhai, last two
fact, the
questions.
lab people should not report amikacin in enteric.
Yeah.
I've been saying that to the hospital, but they say it comes as a built-in report. They cannot customize it. I said,
In
strike it off.
Yeah.
Or make a
now,
footnote.
now Abhay bhai, so many parents, in fact, in periphery, most of the parents, they insist कि साहब एक बार इंजेक्शन आके लगा जाएंगे आप नली रख दो ना दूसरे डॉक्टर तो रखते हैं. So will you give a subtriazone like that?
No, I just say if the child needs hospital, then he needs IV septic. Otherwise, we have to give the quality time, counsel the parent, and we have to counsel them that oral is going to be as good as. No, it's not a good practice to do.
Because this is a real major practical problem, especially
No, but
in periphery.
I think we should get away with that. So we should go only for the
Bajania,
oral. If the child needs hospital, then it's okay. Otherwise, there is nothing like opet in ceftriaxone.
There are a lot of patients who get admitted, they start ceftriaxone, 2-3 days fever is little better. They say, sir, अभी discharge दे दो, we continue. आपके वहाँ आके सुबह शाम लगा देंगे.
पैसे का मामला नहीं है, बस डिस्चार्ज दे देना.
वो बच्चा घर का खाना मांगता है, उसको घर में चाहिए वो चाहिए.
It's always better to manage the patient at home.
Yeah.
There's a lesser risk of cross infection.
Cross infection, local thrombophlebitis.
I always discharge the patient as soon as the fever, some effervescence is there. And I think I've never seen a patient who has been sent on cefaxime and come back and said ki the fever has come back. Never ever. Never ever.
Perfect. Ramesh bhai, continue.
Now Chetan, suppose cultures come negative on day 5 and child continues to be sick. Now develops rash over body, more on palms and soles. He has developed edema of hands and feet. What will you do now? Role of empirical doxy now.
Okay, so I think at 5.
Louder.
Your voice is muffled.
5 years old child. Am I audible?
Yes, 5-year-old child. PUO, thought of entry, started on cefixime. Cultures have come negative, but not only is negative, but is developing some other thing like rash on the palms and soles and edema of the feet.
So I think depending upon epidemiology, we have to think whether it is rickettsial disease or not. But I think this patient may fit in for the Kawasaki also, if it is running high-grade fever. But one thing is CRP is, I think, high in this patient.
80.
So it usually, goes away against Kawasaki. So
and thrombocytosis should be there in Kawasaki.
Yes, at least by now.
Yeah.
At least by now.
Yeah.
Right.
So yes, if we think this can be a case of rickettsial disease, there is no harm. Rather, it should be given doxy trial. And if it responds within 48 hours, it's again a diagnostic that it is a rickettsial disease. Scrub typus, they can be there. But in our part of the country, we don't see much. So that doesn't come to our mind.
So in Maharashtra, it's a real problem in Ratnagiri district and some interiors of Maharashtra where lots of children have rickettsia. And in fact, it's a dictum that a PO who doesn't respond like entry responds like with doxy. That's in fact, the IP paper on guideline on management of rickettsial disease says that doxy challenge itself is a diagnostic test. If you don't have the test to do for the scrub typhus and the pox rickettsial fever.
In Solapur too, no?
Solapur, yeah.
So Dr. Kulkarni was the first one to have hundreds of such patients. In fact, in the medical college there in Solapur was the first to start scrub typhus testing. We used to send samples from Bombay to there with the parents or by courier. And now, of course, it's widely available through chain of laboratories. So that's not an issue. But the question is, when in doubt, treat. There's no harm in giving 2 or 3 days of doxy. Even to a very small child is very safe.
Yeah.
Now Shyam, this fever still continues and now it is day 10. Cultures are negative. Child has developed hepatosplenomegaly with raised enzymes. Counts have fallen. When will you suspect brucella? What antibiotics? How long?
It's another child or it's the same child?
Similar child.
Similar child. This is last part, so you can be at ease. Just finish.
So this patient is culture negative. So different patient.
It's a different patient, culture negative, and the child has got hepatosplenomegaly.
Now it's hepatosplenomegaly with transaminitis.
Counts have fallen.
Yes, counts have fallen. I think any illness, when the counts have fallen, there's hepatosplenomegaly, the enzymes are raised. I think first of all, rule out HLH.
Correct.
This is one thing which is a very dreadful disease and it should be ruled out. And you said another question was how will you suspect
When will you suspect brucella in such a child?
Okay. See, if you take brucella as compared to rickettsia, where the children are very sick, in brucella, they come walking to your clinic. They are not very sick looking. So they may have a fever which is going on in waves for last 2 weeks or 3 weeks. This child has got fever for 10 days. Then they have arthralgia. Then they have hepatosplenomegaly, and then they may have a lot of fatigue and all that. The classical triad which the books mention is fever, undulant fever. Then second is your arthralgia,
Arthropathy.
and the third is fatigue. This is a combination. But we see hepatosplenomegaly, increase amylase, chills, night sweats like you see in tuberculosis. And this is the presentation of these children. And I'll tell the microbiologist that even if I'm suspecting brucella in that situation, I'll tell them, please do not discard the culture. Continue culturing at least for 14 days because
Yes.
brucella may come up on day 11, day 12 or somewhere. So in that case, it's very, very important. As far as the diagnosis is concerned of brucella, I think IgG, IgM, they are quite sensitive tests against brucella serology. You can do that. And cultures may show. And if nothing shows in that situation, our experience is we have seen micro abscesses coming in liver or spleen.
Absolutely.
So these all
Ultrasound.
things sort of make a diagnosis of brucella.
So, Sir Shyam,
Don't
when
go
you
into the
suspect
history
7
of
days, 8 days?
don't go
Sorry.
into the history of they have taken raw milk and all
Yeah.
that. I think
No,
they can.
what? How will you treat brucella, proven or suspected? Combination of drugs,
Combination
cotrimoxazole.
of drugs is I think we give a treatment of 6 weeks with doxy and rifampicin.
Correct.
And sometimes you can give cotrimoxazole with the
Yes.
rifampicin. And this
Yes.
is a treatment to be given for something like 6 weeks. And the patient starts improving very well after 7 to 10 days.
Yeah,
Correct.
very
7 to 10
rapidly.
days.
Correct.
Correct. So I think,
Nitin bhai,
friends, in the 1 hour and 20 minutes, we have discussed most of the common scenarios that a pediatrician will see where there is a need to give an antibiotic, either in the respiratory tract, urinary tract infection, or a PUO. Any comments or are there any questions in the chat box? Chetan bhai, will you see?
Yes,
Yeah,
yes.
there are.
I
There
think
are
there are
comments, and
comments rather than, yeah, let's
Chetan,
see.
please take questions.
so there is one question. What Abhay said that no ear drops, like
Yes.
antibiotic ear drops, because as he said that disease is beyond the tympanic membrane. Suppose there is a otorrhea, that means there is a perforation. Then is there any role of any ear drops?
If it is a chronic otitis media, there is the, otherwise in acute, there is no role.
So if at all the role of ear drops, can you answer that?
So
What is the role of ear drops?
it's a CSOAM, then and then the topical eardrop is there. Otherwise, topical eardrop, antibiotic drops will give more resistant organism at the site. So there is no role of this. On the it will do more harm.
Any painkiller, analgesic ear drops role? Lead or zone?
That I already answered. AAP recommends that it can be used, but I think oral paracetamol is good enough.
Paracetamol,
Yeah.
we say, yeah. There is one nice
And Chetan, even you
comment.
can, sorry, Chetan, you can even avoid giving ear drops in the form of gentamicin and all that. They have a lot of
Absolutely.
ototoxicity.
Yeah.
Yeah, and many of these so-called eardrops have steroids,
Yeah.
dexamethasone. I think there should be completely no. There is one nice comment by Dr. Nandini saying that when discussing the adenoid hypertrophy in child having problem, he said get a sleep video,
Yeah,
if not a sleep apnea total workup.
Yes,
Parents can.
between 2 to 3 a.m.
Yeah, so
Ideally
that,
between 2 to 3 a.m.
yeah, that's right. Then rash after ampicillin, I think we are not discussing side effect. Rash will be no more hip, etiological signs will last. Okay,
We have
excellent.
got Vijay Yavle sir, Jaydeep Chaudhary sir, Nitin bhai.
Azithromycin resistant microbiome is not common for us, Dr. Baldev. We here we disagree with you because we have seen. I'm sure Vijay will agree. We have seen lots of mycoplasma not responding to azithromycin on day 5, day 6. So we almost stopped using azithromycin as the first drug. All right.
There are two
But I
comments of
think
Baldev sir.
if I can sort of
Yes,
make
please.
the statement clear, I think azithromycin we use in our day-to-day practice, particularly in OPD.
OPD.
But in cases who are admitted, in that situation, many a times we have given doxycycline.
Someone asked if there's an extra injury to ear canal or otitis externa, can you use a local antibiotic drop? Like how will you use it in a furuncle? Abhay bhai?
What is the question? Sorry,
In an otitis externa or injury to the ear canal, can you instill a local antibiotic drop?
Not drop. I think we
otitis
can.
media.
No, we can apply only ointment or cream. Why do ear drops?
No, inside there's a furuncle or something.
No, no. If
okay.
it is visible and approachable, we can give
Okay.
local cream over there.
I think most of the chat box questions we have taken. Okay, one last comment from each of the panelists. First, Dr. Sham. What have you learned today?
I think it was a great learning from our friends, and I think rational antibiotic therapy is very, very important. The main reason is if you follow rational antibiotic therapy, you are sort of giving a lot of importance to antimicrobial stewardship. And in this
Bye-bye.
era,
Yeah.
and
Yeah,
in
yeah.
this era, when there is going to be antibiotics where a lot of resistance has come, I think many people have learned that antibiotic therapy must be very rational.
Bye-bye.
I think this rationality should spread beyond the pediatrician. We talk lot of rationality, but other, I think other fraternity, with due regards to them, they do not much worry about this, concern about this. Yeah.
Correct.
One presidential action plan should be like this.
Bhaskar?
Yeah, we have discussed about the common scenarios which are going to help the pediatricians, upper respiratory, then pneumonia, UTI, and fever without focus. So this covers 90% of your OPD practice, and you are becoming a rationalist than anything.
Chetan.
Same thing I wanted to say. If you listen to this 1.5 hours talk, and if you implement 90% of pediatrician and 90% of time, all the pediatrician will be a successful person. So that's
so Bala sir.
Last word from Patriarch of ID, Dr.
Bala
Bala.
sir.
Yeah, fantastic. First of all, my compliments to Nitin and the team. It was fantastic. I could not go to sleep, though I was sleepy. Right? It was fantastic. Hats off to you. Having listened to that, I have a few comments, if you permit me, Nitin.
Please,
sir, please.
Yeah.
Please.
I'll start from the last session on
TU.
last discussion on ear drops. Otitis externa is an accepted indication for topical antibiotics, not otitis media.
Correct.
Even in the NHS, even in the British formulary, surprisingly, neomycin, neosporin ear drops are approved for use in the UK for otitis externa. Otitis externa, unlike otitis media, is due to Staphylococcus or Pseudomonas. So they recommend neosporin eye drops. Neomycin is recommended. So otitis externa, there is no harm in using topical antibiotics, including gentamicin. But for otitis media, there is no role for topical antibiotic. That is my comment number one. Comment number two, in UTI, there was a discussion on nitrofurantoin. Nitrofurantoin should never be used for a febrile UTI.
Absolutely.
For the simple reason, nitrofurantoin, I mean, though it is bacteriostatic, it can work in UTI, but in pyelonephritis, nitrofurantoin will not achieve good concentrations in the renal parenchyma. So nitrofurantoin, nalidixic acid, both should not be used for, or even your norfloxacin should not be used for upper UTI. And in pediatrics, unless the UTI is proven otherwise, it is always upper UTI, febrile UTI. That is my comment number two in UTI. The third comment on otitis media, the extended strength amoxiclav has been introduced mainly because of two reasons. One, to cover resistant pneumococcus.
Absolutely.
You give a high dose, and you also cover beta-lactamase producing organs. The dual purpose is achieved. That is one of the reasons the extended spectrum has come. In India, though we all think that our 40 milligram amoxicillin is working, there is emerging data from CMC Vellore. I am quoting Dr. Balaji's thoughts that middle ear concentrations with 40 milligram are low. Very soon we may be going to the top gear of 80 milligram per kg de novo in otitis media. Of course, I won't recommend it now, but that's going to happen very soon. Third, in sinusitis, I think two clinical points are important for the general pediatrician. Dr. Bhaskar very nicely said the three groups of symptoms. I remember a mnemonic called PWS, persistent, worsening, and severe. That persistent, the pediatrician must remember that rhinorrhea need not be purulent.
Yeah,
If it is
exactly.
going beyond 10 to 14 days, irrespective of the quality of discharge, you should start thinking of bacterial rhinosinusitis. My comment number 2 in sinusitis was that sinus tenderness and sinus x-rays both are unreliable diagnostic clues in sinusitis. Both are and another comment, the case scenario which Dr. Ramesh presented, 7-year-old child with sinusitis. In 7-year-old, it is not the adenoids which is the predisposing factor for sinusitis. It is the viral preceding infection and atopy. I can agree, if it is an infant, if it is a toddler, yes, adenoids are common. 7-year-old is more often secondary to your
Viral.
atopy and your viral infection. And last comment, in fever, if you have a child who looks like having enteric fever, cultures are negative, at least in Chennai, I would tell you, we would straight away start doxycycline if we are giving ceftriaxone. And if we are not giving cefixime, we stop it and change out azithromycin to cover both scrub typhus and typhoid. This is what we do. This is what we do. Last is, what do you do when you do cultures? We all know typhoid, only 70% are going to be culture positive, 70 to 75. The remaining 25%, even if you take cultures before starting antibiotic, the cultures may be negative. What do you do if cultures are negative? Everything points towards enteric fever. That is where I would say holistic clinical judgment, give antibiotics for 14 days. And one final comment is that in UTI, it is preferable to use a higher dose of cefixime to 15 milligram per kg because of increasing reports of resistance to cefixime as pointed out by Dr. Abhay. In fact, in our unit, we prefer to use amoxiclav orally rather than cefixime because our own data suggests that 40% are ESBL. Majority of them outpatient, they respond to amoxiclav. And if we use cefixime, we start with 15 milligram per kg. Depending on the cultures, we continue the high dose or reduce the dose. These are my final comments. Fantastic session. Hats off to all of you for an evening of learning. Thank you very much.
Thank you. Over to you, Chetan Bhai, to conclude the session.
There is Dr. Vijay.
Little louder.
Yeah. Dr. Baldev sir is there. He has made 2 comments. I would like him to come up and just elaborate if you can.
Baldev Bhai is there?
Yes. Jaideep is there, Baldev sir is there.
Because he has put one more comment that impetigo is never hematogenous spread. So no need for going for systemic antibiotics. So that's what, if you can. Or we have Dr. Jaideep, Dr. Vijay sir. Dr. Darur sir.
Thank you. I'm Jaideep here, spellbound by this session.
Thank you. Dr.
It's
Yevle and
OPD
Baldev are
capsule.
sleeping partners.
Very practical, very useful session. And I as somebody said, even if this session is followed by pediatricians, the efforts which we are putting in for last 12 years will bear some fruits.
Yes.
And only one comment that sometimes in enteric fever we start oral cefixime. I've seen a couple of patients where the bioavailability of cefixime is impaired in the inflamed intestinal mucosa because of enteric. So it can take a little longer to respond. And at times you may require injectable antibiotics. Second comment is invariably Vidal-based diagnosis puts you in trouble. Leukemia, Sogia, tuberculosis. There's so many diagnoses which are delayed, misdiagnosed, and then patient is in trouble.
Absolutely. So before we sign off, Chetan Bhai, this recorded for viewing will be available both on the PIDA website as well as on the Gujarat WhatsApp group. Yes.
So YouTube is, we have recorded like online. So, and Zoom.
A little louder, you can't hear you.
So YouTube is available, YouTube video.
Yeah, sure. Okay. You can conclude the session.
Yeah. Now, lastly, Dr. Darur, sir. And then Dr.
Sir, unmute,
Yashwant
Dr. Darur, unmute.
Sir,
Yes.
please.
No, there is one more investigation which people are backing out before doing that one. That is blood culture negative of enteric fever. The next is left is for you to confirm the disease is bone marrow. But none of the group has mentioned about it and try to implement. But they were very enthusiastic in changing the drugs. When you are aiming for the this one limitation of the this one, you have to prove that bone marrow is also negative. Bone
I
marrow
hope
is the only
people
diagnosis.
follow. I hope people follow Dr. Daruru and send for bone marrow to me.
No, it's not. It's not sending to somebody or anything.
No, I'm just joking,
When
sir.
we are,
I do a lot of hematology.
no.
In fact, Dr.
No,
Daruru, I
when,
will assure you that whenever we have a PUO patient and refer to me, whenever I'm doing marrow, the first thing I do is take cultures.
Yeah.
Always.
the first thing, if the first thing PUO has come to you, don't do any other things than a bone marrow culture. That will give you the 100%, at least 90% diagnosis. Whereas if you do other cultures and try to find it out, you have a chance of losing 40% of your acumen.
Right. Okay.
So
second thing is, I did ask one thing, whether the discharge from the nose is right or left, single from the
Bilateral.
only one nose.
That was pointed out. Unilateral, you should worry about. Yeah.
Foreign body and nasal diphtheria.
No, there was something discussion about allergic also. Allergic will alternate. It will never remain on one side. That point I wanted to tell.
Correct.
Second, and lastly, if I am right, the prophylaxis in UTI is being questioned. Please check that one. For any of the condition of UTI, the prophylaxis is not being encouraged, if I am right. If I am wrong, I would like to learn it from tomorrow with some of the urologists.
It is being questioned for last 10 years.
And still practice.
Then, no, that's what. So when we are trying to say something, so let us be very clear, and we will not have ambiguity in our discussion.
In 2018, we had a debate on give prophylaxis or no prophylaxis.
Yeah, so Dr. Daruru, I can tell you that surgeons usually prefer to give prophylaxis. When it comes to smart pediatrician or a nephrologist, they would usually say no need of prophylaxis. Instead, look for symptoms and do a culture before starting any antibiotic if the child is a fever. I think that's a practical.
Regarding the
Nitin, if I have to comment on this,
yes,
it's very simple comment.
What is our what is our pediatrician's opinion?
Sir, if the patient
So one at a time. Dr. Kukreja first, then Dr.
I think if the patient is educated, you may practice that.
Yes.
You tell them these are the signs of UTI. As soon as you get fever, immediately get urine routine test and come to me.
Perfect.
So then it is quite okay. But if this cannot be practiced, in that situation, the second answer is prophylaxis.
Okay. Yeah, Dr. Darur, you were saying something.
Sir, the compliance in the entire India and the other world is not even 40% for a long-term prophylaxis or drugs. So keeping this one in view, when there is a 10 years, more than 10 years discussion about this one, then should we suggest or should not we suggest prophylaxis?
But it is for 2 years now. Now it is for 2 years.
No, so I think my experience is that the nephrologists say that you give it for 2 to 3 months till the time you train the person in correct hygiene and constipation management and good urinary flow by having a lot of fluids. And they are asymptomatic after 3 months, just stop it.
Yeah,
I mean, that is what the nephrologist will do.
Yeah, so if there is no UTI in last 1 year, and if the child is toilet, and you can stop it.
Yes.
And if there's no
and lastly,
in problem.
Lastly,
yes,
any CSOM or ASOM that comes, we take the help of the ENT surgeon who does entire thing and he gives his opinion and the treatment. We do not find any persisting or recurring ASOM or CSOM in our hospital.
He gives Texim.
Correct. Dr. Rangnath, I would say
Dr.
that
Daruru, unfortunately,
1 minute, Vijay. refer to ENT only for surgical reasons. Otherwise, they'll end up giving azithromycin and levofloxacin and God knows what antibiotics.
So they give opinion and steroids.
No, sir. No, that's not the practice. The practice is entirely different because the patient comes back to us and we said,
that's right.
they are
So,
equipped. No, they are
we should guide them for
right?
antibiotics.
No,
Whatever
right?
ENT fellow has written, we should guide them for antibiotics because we are
No,
better
the
off
right.
than.
No, equally educated professors are there. So we interact with them. We take the opinion even before starting anything in the for ASOM or CSOM, because you should have the picture of the drum that is going to eardrum that is going to decide. So we can't do here. They will do and send that one to us. Then we'll decide.
Sir, due respect to all the ENT surgeon. A very close friend of mine has a roaring practice, quite rational ENT surgeon. But when it comes to otitis media, he says, "Rene, they are rational therapy, steroid." So ENT surgeons are ENT surgeons. They will never listen to you.
Anyway, let's not discuss in that. Come back to our. I think time to wrap up. Chetan is almost 1 hour and 45
But
minutes.
it was but it was a very good discussion.
Thank you.
Because it has tried to bring out all the controversies and their answers.
Yes. Thank you. So just last comment from Dr. Baldeva. He has been on the screen on the screen, and then Dr. Yashwant will submit up Thanksgiving.
Okay.
Baldev sir, unmute yourself.
Sorry, actually, I could not attend the whole session. In between, I could, but I think the whole discussion was most practical, and I'm sure that it makes difference in the practice of our friends pediatricians. Certainly, it is going to be useful. Thank you very much.
Sir, YouTube पर જોઈ લેજો થોડી વાર પછી.
Okay, Yashwant Rao.
Yeah, thank you, Chetan bhai. It was wonderful. We started first out of the 11 with rational approach of all the 4 disorders which you said. 90% of the practice will become rational. Hope PIDA and the Gujarat pediatricians will help all the pediatricians to fall in line. As sir was saying, 12 years of efforts will bear the fruits, and we'll have a wonderful series ongoing. We had 2 moderators, Dr. Nitin Shah and our Vice President West Zone, and learned speakers, Kukreja sir, then Bhaskar Shana sir, chairperson, our Chetan himself. It was a wonderful learning, and crystal clear messages were given on use of antibiotics in otitis externa, middle ear, why we should use, why we should not use. UTI prophylaxis discussion was very clear, and messages by seniors. Thank you one and all for sparing 1.5 hours, 1 hour 45 minutes precisely. Thank you one and all for participating and having your valuable time on this day. Thank you so much.
Thank you. Thank you
Bye,
very much.
everybody.
Bye-bye. Good night, everyone.
Nitin
Bye-bye.
bhai.
Thank you and good night.
Last question to Nitin bhai.
Yes.
Are you a vaccine expert? Are you a hematologist? Are you ID expert? Who are you?
Sir, I'm a juggler. I keep on changing my hats.
Omnipotent.
All three.
Oh, sir, thank you so much. Thank you.
Superstar.
Thank
Thank
you
you so much. Thank you so much.
Good night, everyone. Good night.
Master of all.
Thank you, sir. Thank you.
Good night.
Bye.